All right, welcome everyone to today's webinar. We're going to go ahead and get started. I got the top of the hour, and before we do, I'm going to just go over a couple of housekeeping items. If you would like to ask a question during this presentation, please use the chat feature, which is found on the right side of your screen. And just a reminder that this webinar is being recorded, and we will provide a link to this presentation from our website. So I'm going to turn it over to our speakers and let them introduce themselves and their topic today.
Hi, everyone. We are joining you all to share some information regarding some significant changes that are happening in the behavioral health care system. I am Marquita Little. I'm the Director of Policy and Planning for the Arkansas Department of Human Services.
And I'm Paula Stone. I'm with the Division of Behavioral Health Services.
And so we'll just go over some material. Some of you joining today may have heard some of this information before. We've been kind of going throughout the state really for almost 2 years now, sharing information on the new proposed model, and also it's changed a lot. So even if you've heard this particular presentation or bits and pieces of it, it's probably actually evolved because we've constantly made adjustments as we've shared this information with providers throughout the state, consumers, stakeholders, so that we can design a model that works for Arkansas. So we'll go ahead and get started to ensure that we can preserve some time for questions and feedback. So the broad agenda today, so first we'll do a bit of an introduction and just a little background information. Then we'll discuss in detail the health home model, as well as proposed new services in our behavioral health system. So why did we see the need to approach this initiative in the state of Arkansas? So we know that there are some major health challenges that we are currently facing in our state. Health status of Arkansans tends to be pretty poor. When you look at various health rankings, you look at things like heart disease, even access to behavioral health services. We are near the bottom, if not at the bottom of the list in many of those instances. Also, our healthcare system can be pretty tricky to navigate. And we know that there are some providers who do create some ease in working with their patients and navigating the system, but our current healthcare system does not reward those providers. And of course, in both the public or Medicaid side as well as the private side, we've seen healthcare costs continue to grow. And that can be challenging for employers, it can be challenging for families, and even for those insurance providers, Medicaid or those private companies. So today we are specifically focusing on the behavioral health aspects of our healthcare system. And so we really started this entire process by, again, going out and having conversations throughout the state over a period of about 11, 12 months just to talk about what are some of the current challenges. So what do we need to resolve or fix in our current system? And as you can see, I won't read it all to you in detail. You can see it, but just highlight a few things. So first, you can see that we have some challenges across our entire continuum of care in the behavioral health care system in Arkansas, really through the stages of prevention all the way through recovery, resiliency focus, and then those screenings and assessments. And then when you look at each of those areas, you see the repeated word gaps, 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 because we have gaps in each of those areas. And also one area where we've received a lot of feedback is regarding the screening and assessment component that we don't necessarily have in our system. Consistent screening and assessment processes, no standardized tools for screening and assessment. And also a major theme that came up is that there tends to be a more availability of services and treatment when you're really focusing on the treatment aspect and very much that more intensive treatment, and there's not as much available or more difficult to access any prevention services. So when we approached making some improvements to our system, these are the very challenges that we're hoping to address. So just some key facts on what what we're talking about here by way of cost and the population being served. So the changes that we're proposing today are specific to Medicaid. And so this slide provides just some general information on the population. At the time when we ran this was state fiscal year 2011, and so the numbers have changed just slightly since then, but we're pretty much still seeing the same trends. So we have about 110,000 Medicaid recipients who receive behavioral health services. And then we looked at what the costs are associated with those services, and so that's broken out into core and halo. And so when we talk about core behavioral health spend, we're referring to those dollars that are specifically spent to provide behavioral health services to an individual. And so that doesn't include anything like treatment for dementia or developmental disability services through Medicaid, only those things specific to their behavioral health condition. But for that same population, they also may have some non-behavioral health related needs. And so the core spend, the halo spend refers to those non-behavioral health needs, and so that could be for various medical services, personal care, attendance. So when we look at the core spend on those behavioral health services, it's about $550 million. And as you can see, 38% is for inpatient and about 62% outpatient. And then when you look at the non-behavioral health spend or related medical costs in that same population, that halo spend is an additional $380 million, and the pharmacy spend for this population is $150, and that includes for the behavioral health condition or any related medical conditions. So this next chart delves a little bit more deeply into the $550 million related to those behavioral health services. So this chart just kind of plots out where that $550 million is going. So each bar on the chart represents about 5% of the population of that 110,000 people. So it's about 5,000 people when you break it down to 5%. So just two things to point out on this chart. You look at that really high bar on the right. That bar, again, represents only 5% of the total population, but 5% of the total population accounts for 52% of the spend on behavioral health services. And then if you go out just a little further and you look at the top 20% of individuals, that accounts for about 81% of the total cost. And so what we see is that we have a small portion of the population that's really driving that cost, but that also translates to a small portion of the population that tends to have a much higher level of need. One other question that frequently comes up, why is the youth bar so much higher? There seems to be so many more youth in the system than adults, and that is absolutely correct, and it's because of at the time that this information was pulled, because of our Medicaid eligibility requirements, we serve more youth than we do adults. So you just have fewer adults in the system because of the requirement that you essentially are disabled. Now, we know that has changed recently with the expansion of Medicaid or private option in our state, and so we anticipate that mix may change to some extent, but currently in our system, this is what we see. And so when we look at those individuals that account for that 81% of the cost, we have some questions about just additional information and detail. So on the next couple of slides, we'll look at the diagnostic profile. So on this slide, you just see the adults split out. And when you look at the adult population, you can see that the most prevalent, and again, we're only looking at the top spend adults. You can see that the most prevalent diagnosis is schizophrenia, followed by bipolar and depression. And so what that tells us is that for this portion of the population with the high spend, they tend to have more complex diagnoses. Those diagnoses that really, the necessary treatment can vary greatly depending on that person's functioning level, coping capabilities, supports, et cetera. And then when we look at the youth in that top portion of the spend, we see that the most common diagnoses are ADHD, ODD, and unspecified. And those of you who have been involved in some of the previous conversations on our Payment Improvement Initiative, you know that we have launched an episode of care to address the needs of, better address the needs of youth with ADHD and ODD diagnoses. But even in designing the episodes of care, you can see that about half of the population for those youth with a high spend still have conditions that are not being addressed through an episode. So this is really about how can we design a model that addresses the needs of the entire population. And then if you're just interested in more information on the unspecified category, because it was such a high number, particularly in youth, there's just some additional detail here on what we're seeing in the unspecified diagnosis. So what's our vision for addressing these needs? So again, our broader payment improvement initiative is designed to provide a comprehensive patient-centered delivery system, and that system should better meet the needs of patients as well as providers. And we're doing it in a couple of ways. So on the right, you see the episode-based care. And so I referenced that we have the behavioral health episodes around ADHD and ODD. And so those episodes are really designed to address the needs of specific diagnoses, and those diagnoses are acute, post-acute, or chronic conditions. But we know that there is a large population of folks who have needs beyond those individuals with those specific medical or behavioral health diagnoses. So in order to address those needs, we've designed several population-based care approaches. And so one is your patient-centered medical home. And I think the patient-centered medical home is sort of a beefed-up primary care practice or physician. And so that patient-centered medical home is really intended to manage primarily the medical condition and oversee kind of the overall well-being of the individual. And so everyone in the system will have a patient-centered medical home. But there are certain individuals that have a higher level of need related to those certain chronic conditions. And for those individuals, they might benefit from an extra layer of care coordination or care management, and so that's when we bring in the health home model. So again, everyone would have a patient-centered medical home for primary care and management of medical conditions, and some people with the highest level of need would also potentially be eligible for a health home. And we're designing 3 health homes, one for individuals with intellectual disabilities, also people with long-term care needs, and then a behavioral health home. And so today we're talking in detail about the design of the behavioral health home. So what are the goals of the behavioral health home? So the overall goal of the behavioral health home is to deliver integrated care in a timely manner that facilitates quality and positive outcomes. And that's done in 2 ways, by providing care coordination and managing the core care delivery. So when we talk about care coordination, really that health home is providing the client with integrated coordination across any system that they might have involvement in. And so whether they have certain medical needs, behavioral health needs, the system might vary. If it's a child, they could have certain needs in the school setting. If it's an adult, they could have some additional needs around employment support. So the health home would provide that level of care coordination across systems, and the health home also manages the core care delivery. So the core care in this case being that behavioral health condition, ensuring that that condition is being effectively managed. So what is a behavioral health home? So in Arkansas, for our model that we have designed, a behavioral health home is a behavioral health agency. The health home also provides extra support for people who benefit from an increased level of care management, or people who might have some challenges navigating the healthcare system because maybe they have needs in multiple systems. And again, I mentioned that across-system coordination. The health home also promotes quality in that there are certain quality measures that have to be met in terms of client outcomes. And then it really goes a step further than just promoting quality and encouraging coordination, but it also provides those financial incentives for those providers who do offer clients that extra layer of care management. So a behavioral health home is not a direct provider of medical services. Again, I mentioned that patient-centered medical home is providing those medical services, and we'll talk on a future slide just about kind of the relationship and coordination between the two. The health home is also not a gatekeeper. It doesn't restrict a client's choice. Client choice is always primary, and it is not a physical house. So it's a model and concept for how you better manage care. And it's also not an organization that requires providers to have any type of contractual relationships in order to meet their clients' needs. And so, our model is broad enough in that if providers choose to have some type of contractual relationship where they partner to better meet the needs, they certainly can do that. But our model does not require that in order to achieve that care coordination. So here's just a broad schematic of the new system that we are proposing. And basically in our new system, we know that individuals have different levels of need. And we saw that when we looked at the diagnostic profiles, when we looked at the current spend. And so we wanted to design a system that is specific to meeting the needs of each of those groups of individuals. And so when we looked at the data and information, individuals' needs seem to fall in about 3 categories. And so you see that reflected here, Tier 1, Tier 2, and Tier 3. And within each of those tiers, there's a different level of care management being provided as well as appropriate services to meet their needs. So just a quick overview of the difference between those tiers. So in Tier 1, these are individuals with a relatively low level of need as it relates to their behavioral health condition. So those individuals, they may be receiving some clinic-based services. They might also get medication management from time to time, but they don't have a very high level of need, and they're managing their behavioral health condition pretty well. So for those individuals, they will primarily be receiving their care management through their patient-centered medical home. And so that patient-centered medical home should be working closely with their behavioral health provider if they have a separate one, or in some instances you might see that the patient-centered medical home is actually managing and treating the behavioral health condition. So a good example could be a child with ADHD that responds well to medication, and that patient-centered medical home helps to manage that condition. If an individual, if the behavioral health provider, patient-centered medical home, if there are concerns that their needs are greater than what is being provided in Tier 1, then that individual might be referred for participation in a health home. So that's where you see Tier 2 and Tier 3. And in Tier 2 and Tier 3, that behavioral health home is providing an extra layer of care management specific to managing that behavioral health condition because there's a higher level of need or the individual's functioning level, based on their functioning level. And so Paula is going to walk us through some examples just to better illustrate the type of individual that might be served within each tier.
So this first slide is for children that you would see in different tiers. In Tier 1, you might see someone like Ben, and Ben is age 6, and he's been diagnosed with ADHD for about a year. His family's engaged in treatment, and he lives in his family home with one sibling. His performance in school is much like you would expect with an ADHD child. He has average cognitive development, but he's easily distracted and tends to be the class clown. He's had difficulty keeping friends, and he's generally friendly but impulsive and a little socially immature. So he's been receiving treatment. The treatment has been helping him. His teacher's seen some improvement over his behavior in the past few months. So with Ben, he would be able to be treated on an outpatient basis and continue the same treatment, would not need additional care coordination at that time. In Tier 2, you might see someone like Tom. And Tom is 8, and he's been diagnosed with a comorbid condition of depression and ODD. So right there you see a little bit more complexity in the diagnosis. Tom continues to display some very oppositional behavior at home and at school, so it's beginning to impact his academic performance. So we see another system being brought in with the issues at that time. Tom's family is involved in treatment, and they attend the family therapy sessions, but they haven't been successful implementing some of the strategies in the home. His parents are asking for more support in the home environment, and his teacher is asking for more support in school. You can see that we would need some additional services as well as some additional coordination for those services in those different environments. His therapists and parents agreed that he doesn't need to be in residential treatment, that they believe if they had those additional supports that they would be successful. In Tier 3, you might see someone like Annie. 14, and she's been diagnosed with bipolar disorder, and she also has oppositional symptoms. And she's recently started to make suicidal statements, a very complex set of symptoms and issues. She's currently living in foster care and has been with her current family for 2 years, and she's had multiple acute inpatient stays due to her suicidal threats. Her academic performance has declined over the past 2 years, and her family service worker and her therapist are considering admission to residential. So not only with the complexity, you see multiple systems involved, as well as a need for assistance with transitions. So you would see care coordination helping with those transitions in and out of residential or an acute, and between coordination between the school, the foster family, the DCFS caseworker, the therapist, so lots of coordination opportunities as well as assistance with transition. Now some examples of profiles for adults. A little bit different profiles here. In Tier 1, you might see someone like George, who's 26, and he was diagnosed with depression 2 years ago. He had previously been in Tier 2, but he's greatly improved. But you also can see with transitions right here, is transitions between tiers as well can occur. So George now manages his depression through regular medication appointments and occasional clinic-based therapy, and he's living independently and maintains a steady job. So he wouldn't need that additional care coordination. His care coordination could be done with the primary care, the person-centered medical home, and he could receive services from a Tier 1 provider. And in Tier 2, you might see someone like Roy, who's 32, and he's been diagnosed with depression and drug addiction, but he's on his path to recovery. During his recovery, he experienced a crisis event, and he relapsed, lost his job, lost his apartment, and was undergoing intensive outpatient substance abuse treatment at the time of his relapse. Roy and his therapist are of the opinion that his recovery would be likely successful if he had an opportunity to enter a partial hospitalization program and begin working with a peer specialist. So there you can see there's been some transitions in Roy's life, and that we want to also be able to have a care coordinator work with someone who had been stable but suddenly had some crisis events happen. There's lots to coordinate in this situation with transitions into new types of services, as well as assistance helping Roy find some stable living environment. In Tier 3, you might see someone like Liz, who's 44, been diagnosed with schizophrenia and has substance abuse issues. So complex diagnosis and multiple different issues between the mental health and the substance abuse. Liz has also been recently hospitalized, and she's currently in a residential substance abuse program. So she will need some help with the transition back into the community, which would include ongoing behavioral health and substance abuse treatment, and then also need help with housing support, assistance with her budget, and help in meeting her nutritional needs. Liz also has a history with the criminal justice system and is at risk of returning to jail if she relapses. So lots of different issues to coordinate, lots of different systems to have an integrated care plan to coordinate all of those different things that Liz needs.
So what type of care management services are these individuals in Tier 2 and 3 who have the more complex needs and multi-system involvement? What is the health home providing? So this slide just provides more information on what we mean when we say care management activities. So the health home will provide care coordination, and so again, that's that across-system coordination. That's making referrals, assisting with scheduling appointments, regular check-ins with the client to ensure that they don't have any barriers to adhering to their treatment plan, and also monitoring those chronic disease indicators. And so, for example, it might be coordinating to get information from that patient-centered medical home on their blood pressure or how they're managing their diabetes. So not necessarily performing that function, but at least monitoring and being aware. Also, the health home will provide health promotion, and so providing that diagnosis-specific education to the client and their family, assisting them with developing a self-management plan. Also support services. So we expect the health home to develop relationships or have access to additional support services in the community so that they can match individuals with the appropriate support services. Also, the health home should be always aware of what these key services are. And then finally, comprehensive transitional care. And so Paula talked a lot about those transitions when she went through the profiles of the types of individuals who would receive services in a health home. And so that health home is helping to manage those transitions and actually plan for those transitions. A person could be transitioning from one type of service to a new type, or they could be transitioning out of a residential treatment facility back to home and community-based services. And so that's what that health home would assist with, developing transition plans, also ensuring that that individual has a crisis intervention plan as well, and then working with the family to ensure that they are aware of what those plans are. So now we're going to talk about some of those proposed new services in our system.
So we know that all the care is going to be coordinated through the behavioral health home. But in examining the system and looking at some of those system gaps, we also note that we have some needs for some different services. And so looking at those services, we first looked at our guiding principles. And our guiding principles are that we want the services to be family and consumer-driven and person-centered. We want to support and promote evidence-based, recovery-oriented practices. We want the services to be customized, culturally and linguistically competent, and community-based. The services should be offered in the least restrictive care setting. We want the services to be utilized through a team-based approach with treatment decisions to address the service needs, and we want to ensure services are high quality and based on data from outcomes. I think if we honor all of these principles, it will support our triple aim of improving health, increasing quality, and lowering the growth of healthcare costs. So we look to, because this is a Medicaid initiative, we look to CMS, the Centers for Medicare and Medicaid Services, to see the best way we could support those service needs that we know are in our community at this time. So we looked at different services that we could use, and we looked at the 1915I, which is a waiver-like state plan amendment, which would allow us to use community and evidence-based practices. It would allow us to draw down federal funds to support reimbursed services, and it would allow us to target the benefits to a specific population, in this case being behavioral health, and allow us to use services that differ in amount, duration, and scope for that behavioral health population. So the 1915I is a lot like a waiver. If any of you are familiar with, there's a C waiver that currently supports the DD population, and it is very much home and community-based services. But this one was done, there was some basis for this in a psychiatric residential treatment center waiver demonstration that CMS did to help children and adolescents stay in their home and community, and looked at all the different kinds of services that would be needed. And Medicaid did recognize that some of those services needed to be offered to any state in the United States that felt that they could apply that in a way that would be helpful. So with anything that CMS does, we have some specific regulations that are required of the states if they're going to use those federal funds for services. In the case of the 1915I, one of the requirements is that to access the services, there must be an independent assessment. And that independent assessment has some regulations, which is that it has to be face-to-face, that it's used to determine the necessary level of services and support, that it evaluates functional need, that the independent assessor consults the individual as well as the family and significant others and the treating providers, that there's a review of patient history, and that beneficiaries must be reevaluated every 12 months to see if service needs have changed. So we know, working in this field, that service needs can change pretty dramatically in a year. People can get better. The services being provided can work, so they may not need services in such an intensive manner, or people have crisis situations, and so they may need more services or a different service array. So we want to make sure that that's evaluated every 12 months. And I'm going to jump back to the evaluating the functional need and talk just a second about functional need. So we know that these individuals that would need these services had most likely already seen a therapist and had received a diagnosis. And so we're not going to have the independent assessor, and Medicaid does not require, or CMS does not require that the independent assessor give a diagnosis, rather that they review the diagnosis and then make an appraisal of the functional need. And that means how the diagnosis is affecting the individual's ability to function in their community. So the 1915I independent assessment, we've already identified the instrument, an instrument that's being used across the department with the developmental disabilities and long-term services and support, and it's called the INTER-RAI, and that's I-N-T-E-R and then capital R, capital A, capital I, INTER-RAI. And there's a separate instrument for children and youth and then an instrument for adults, and we're currently using the instrument in the state for a pilot, and our pilot is helping us set up an algorithm to determine tier assignment across the population. So we've done a random sample of our current service population, and we have providers that are providing services that are currently using the instrument. That instrument, those instruments are going to be brought back, and we have a panel of experts that are looking over the instruments, and we're making some decisions as to tiers or what would be the tiers in the new system, and developing the algorithm. I do think I see one of our expert panel members on the call, so if questions come up about that, I may kick that to Adam. Also, with the 1915I, in conjunction with the 1915I, there would be a health home. So one of the health home requirements, which is also funded through CMS, the health home requires an integrated care plan, and that care plan has to be person-centered, also developed in consultation with the individual and treating providers. That integrated care plan should identify the necessary home and community-based services. It should prevent inappropriate care, and a coordinated care management, health promotion, support services, and comprehensive transitional care. So on this slide, this brings it all together. So you can see at the top that not everyone in the system would have to have that independent assessment. Only those with the complex needs or needs for coordination across multiple systems would need that independent assessment. On the far left, you see Tier 1. And Tier 1 services are for those individuals that do not have that complex diagnosis and can be managed in an outpatient setting, receiving therapy services and clinical services. So the care management in that situation would be performed by the PCMH, the Person-Centered Medical Home, and all Medicaid beneficiaries would have that Person-Centered Medical Home, not just those with behavioral health concerns. So that would be the management there, and then we would have outpatient services provided for those individuals. I think one of the important things to note about Tier 1 is with Tier 1, there would be no initial prior authorization for services. So we try to model this off of private insurance and individuals who are able to receive behavioral health services through private insurance plans, and to lower the paperwork requirements and for that. So we wouldn't be requiring a large treatment planning process. We would want people to be able to access the services, access them quickly. We hope that this would encourage individuals in private practice to begin accepting Medicaid as a reimbursement for their services and be part of that provider panel, as well as behavioral health agencies So we know that people may want to, we know a lot of times people utilize, maybe come in and have a service, maybe 2 or 3 sessions. They may stabilize, leave, they may come back in 6 months. So just to accommodate that and make sure we're meeting people where their needs are, that would be Tier 1. If a person's in Tier 1 or out in the community and they have significant needs, more complex diagnosis involved with multiple systems, then they might need an independent assessment. That independent assessment would be done. The independent assessment will be done by an independent group. So we would be releasing an RFP for an independent assessment entity that would be able to cover the state with assessors, that would be able to meet with people in their home environment and conduct this independent assessment. The independent assessment would lead to the independent assessment report, which would determine that tier need. If they're deemed to need Tier 2 or Tier 3, then they would choose a behavioral health home. The behavioral health home would develop the integrated care plan and develop that service array list and continue to do the care coordination. The service array would be given to a behavioral health agency, and the behavioral health agency would have a clinician, a therapist that would have a master treatment plan, so that wouldn't change. So that master treatment plan would be part of that integrated care plan. So the integrated care plan might include a DCFS caseworker plan, an IP in a school situation, some plan from the probation officer. So all of that would be integrated, and then the therapy services and the other services would be provided by the behavioral health agency. Again, you see the PCMH, the person-centered medical home, also continuing to work with that behavioral health provider and that care manager for any medical needs. As you see at the bottom, we have some expectations of how many people might be in each tier based on that slide way back in the slide deck that Marquita went over where you saw that top 5%. So what we expect is in Tier 1, we would see a total of the original 110,000, 90,000 people in being served in Tier 1, about 10 to 15 in Tier 2, and in Tier 3, approximately 5,000 people. So this slide gives you the list of services that would be available in each tier. So a couple of things to note about this slide is that if you're in Tier 3, all the services below you are also available to you. So those are cumulative services. Also to call out, in the bottom blue bar, you see services that we want to make sure are available to all tiers. So you would not need to go through an independent assessment. You would be able to access those services when you had the need. So that's acute psychiatric hospitalization. Access to acute psychiatric would not change from the current system. We would also add mobile response and crisis stabilization, which again we would have, we haven't determined the entity that would be doing that, but we would make sure that mobile response would be available for children, youth, and adults. We would also have acute crisis units for adults, substance abuse detoxification, and intensive outpatient substance abuse treatment available to all tiers. You can see in gray are the services provided by the health home, and that's care coordination in Tier 2, or care management, and intensive care management for adults in Tier 3, and wraparound facilitation in Tier 3 for children and youth. So we'll go up to the services. In Tier 1, you see the services in blue across the page are expanded services. The services in black are existing services, and the services in red are proposed new services. So in blue, one of the things to note in Tier 1 is you see individual behavioral health counseling and group behavioral health counseling. And we have behavioral health. We originally started out with having mental health counseling and substance abuse counseling as two separate services, and those have been integrated due to the needs of those with co-occurring conditions, wanting to make sure that the treatment for them is as seamless as we can make it. And so behavioral health would include mental health and substance abuse counseling. We would just have modifiers for the billing of that. Also see marital and family behavioral health counseling and multifamily counseling. Psychoeducation is a brand new service. We have mental health diagnosis and interpretation of diagnosis and substance abuse assessment. What you don't see here, again, is master treatment plan. And to also note here, we have a psychiatric assessment, but it would not be a required service as it is now. It would be a service that you could access or refer a client to if needed. Maybe you might need a psychiatric assessment for a differential diagnosis or for pharmacological management. So it's not required, but available. In Tier 2, you see some of those services in black, the master treatment plan, the home and community-based individual psychotherapy and group psychotherapy are services that are currently now offered through the RSPMI program. But the new services in red are those services that we're able to provide through the 1915I, which includes home and community family psychoeducation, partial hospitalization. You see behavioral assistance, and that's for children and youth, and aftercare recovery services for adults. And then also really exciting that Medicaid is also allowing us to reimburse for peer support and family support partners. So peer support is for older youth and adults, and that is someone with lived experience. So someone who has been diagnosed with a mental illness, received treatment, and is in recovery, and is able to provide those supports for peers. And then family support partners, we've been running a small demonstration project with some state general revenue for family support partners. It's been very successful, and that is, again, we call them legacy families, but those are families that have a child or a youth that have a mental health disorder, have received treatment, have walked that path, and are able to help other families in a way that a professional is not able to do. They would be part of the team that provides intervention for those individuals and families. And then in Tier 3, you see everything is in red as new in the home and community-based section. So individual life skills development and group life skills development is for transition age youth. Child and youth support services are intensive services for that family, child, or youth. We see that typically those very intensive services provided in the home and community setting, either to help a child after they've transitioned out of a residential facility or to keep them from going into a residential facility. So very intensive services provided to help that child integrate into the community. And then individual recovery support and group recovery support are more intensive services for adults. And individual recovery support and group recovery support include things like supported employment and supported housing, those kind of things that help adults also stay in their home and community. Residential services would be accessed through the behavioral health home, which would include planned respite. You see in black the residential treatment unit and center, and that is the current system that we have now that is available for children and youth only. And then we've added short-term residential treatment for adults as well as therapeutic communities for adults. So I like to always stay on this slide. There's a lot of information to see if there are any other questions. I know that do we have until 1? Yeah. So we've got about 15 minutes for questions, and if we have time, we can go through the client journeys, but if not, allow for questions now.
Yeah, and certainly you all can, we just include that to kind of provide an example of how someone would navigate through the system, and so certainly you all can look through those. You know, it'll help, I think, kind of bring together a lot of the information that we talked about today, even if we don't actually get to walk through one. It's just really useful, I think, to read through it.
I have 2 questions. I'm to the speakers, and so I'm in the audience. So I hope you can hear me, that those of you who are on phones. When we have a lot of folks through our best that work with clients who are either in child advocacy centers or they're mental health therapists that are affiliated with child advocacy centers, and a lot of times they'll start them in an assessment and then do a treatment. So that would kind of qualify for the Tier 1. Not all of them bill Medicaid, but it sounds like it's going to be an easier process, so they may be able to start that. So the question then is, they get in to start seeing this client, and they realize that it's more complicated. How do they then get to that tier? How do you activate that Tier 2 independent assessment and Tier 2 process?
So we'll have a referral process established, and basically a standard sort of referral form. It may be something electronic. I'm sure we'll do it in various formats, maybe hard copy and electronic. But basically, part of what that independent assessor entity will be doing is helping us get some of that stuff set up and established. But essentially, it would just be a direct referral, sending that referral to the independent assessor entity, and they have certain timelines and requirements for how soon they have to contact that client or that family to come out to schedule the assessment. And we've actually also built in the event that there's a crisis situation or certain circumstances where this is someone who really needs to have their assessment so they can access those more intensive services sooner rather than later, we have condensed timelines for certain populations. But basically, it'll just be sending that referral directly to the independent assessor. And I can't remember off the top of my head, but it's like a day or two, but at the least before they have to at least make contact with that individual.
And then my second question has to do more with the behavioral health home. Kind of administratively, I mean, who are they accountable to? Are they accountable to division? Are they accountable to Medicaid? Who do they actually report up to, or who kind of oversees all of the operations that they do?
Yeah, that's what I was going to say. I think it's both. So the behavioral health home, so there would be a certification that would be a division of behavioral health services certification. And so part of the certification would be for the behavioral health home is we would have behavioral health agency provider certification. So each health home will have to be a behavioral health agency provider as well and provide some or all of that service array. And then there would be an additional certification through the Division of Behavioral Health. Also, the funds are coming through Medicaid, and then they're Medicaid funds, so there would be Medicaid regulation for those behavioral health homes. So there would be a dual answer to both. They would have to follow the certification policy as well as the regulation.
Very similar to today's system for those current behavioral health agencies. Right. They have to meet the certification requirements that the division oversees, but they also have certain policy requirements since Medicaid is paying for those services that they have to meet.
Thank you.
If folks do have questions, feel free to type them in. You can click on your chat bubble. We'll stay on for a few more minutes and see if any questions come in.
So also kind of bank off of that with the behavioral health home, with the performing provider, so the care coordinator, there would also be a training and certification for those individuals that will be doing the care coordination. And so that would be coming from a contracted entity with the Division of Behavioral Health. So there would be that certification process as well for those who would actually be doing the care coordination.
And I guess more broadly, since Paula mentioned a contracted entity, so we know that this is a major change in the system. We know that even just with the primary care changes and those patients that are medical homes, even operating and moving in a more integrated fashion, that has an impact on the behavioral health system. And then we know for those agencies that want to be a behavioral health home, there's going to be some process to get there. And so we will be developing what we have yet to name, but basically some center of excellence, provider support center, that will provide necessary training, TA, et cetera, to help as a part of the transition. And it'll be everything from the training required for some of like the care coordinator certifications or the family support partner trainings, and just broader trainings on, integrated care, what is an actual health home, the operations of the health home. So we know that there's a great need for that level of support in order for the system transformation to be successful. And so that is happening now, actually, in terms of trying to assess what some of the needs are so that we can include that in RFP to get the appropriate services out there, or supports, I should say, rather.
Okay, well, we are not seeing any questions coming in, so I guess everyone's trying to get started early on the weekend and enjoy the nice weather. If you do have questions, most of you should have my contact information. I'll be sending you slides out in email, so if you lost my email or whatever, you can follow up with questions. I can forward them on to folks. So with that, I hope everyone has a great weekend, and thank you to our presenters. And we'll be announcing our next webinar shortly, so look for that email. Take care, everyone.